warm greetings from Global Hospital Hall. So to see you to everyone here. And today we'll be discussing on an approach to ascites in chronic liver disease patients. So in first half of the talk, we'll have it as an interactive session. I would want everyone to have an informal interaction because it would be a case-based discussion. And in the second half, I would be going through the international guidelines. And then lastly, we can have questions for you. So my aim today is that at the end of the talk, I should be learning from you all, and probably what message I have prepared to impart, maybe it can be carried forward. Okay. So is it okay? Is my voice audible? We can just have it as a discussion rather than me waiting at the mic. Yeah. So this is the case, and I would want everyone to give their inputs on the case on the basis of questions that would be coming next. So this is about a 50-year-old male who was a chronic alcoholic. He had diabetes. He walks in your OPD with progressive abdominal distension and swelling of feet since past 1.5 to 2 months. We do the basic examination. We find him to be obese, and he has a BP of around 100/60. Pulse is okay, saturation is okay, has some jaundice, pedal edema. You find ascites on clinical examination. He's conscious oriented, not having any flaps. So patient is smart enough. These days patient come in कि पेट में पानी हो गया है तो सोनोग्राफी लेकर ही आ जाते हैं before we advise. So he comes in with a sonography report showing moderate to severe ascites and features of chronic liver disease. So how would you want to manage this case in your clinic? So if anyone would want to volunteer, then we have the options. Would you want to start low-dose diuretics immediately and observe for improvement? Anyone for that option? Option A. Okay. Would you start restricting salt and water intake to 1 liter and observe for improvement in this case? Any take on this? Option 2. Would you admit this patient, investigate and plan therapeutic tap of fluid and relieve his abdominal distension? Anybody favoring option 3? On OPD basis, you would want to investigate and plan for a diagnostic tap. Any more? So I think we have takers on option D. So I would want to investigate him because it's a moderate ascites. Patient has come walking, not critically sick. I would want to go ahead with the diagnostic tap first. Okay. So along with diagnostic tap, we do some preliminary labs as well. If we find him to have low platelet counts, we do his LFT. We find that he has some hyperbilirubinemia. INR is 2.6. OTPTs are like of a cirrhotic range of 50 to 23. Low albumin. Creatinine is 1. We don't know what his baseline creatinine was. Sodium is 126. Potassium is okay. We calculate a sodium melt. How frequent do we calculate sodium melt in a patient of liver cirrhosis? Regular. Okay. Great. And CTP score is 12C. He is HH negative baseline investigations to understand if he had any viral etiology. Again, thyroid normal, routine 2D echo we do to rule out any cardiac involvement. Grade 1 diastolic dysfunction, ejection fraction 60. Now, of course, I mean, I have not given a detailed 2D echo description which you guys would want, but then 2D echo is acceptable. IBC screen was non-collapsing. So, what is your preferred site and method of ascitic tap? Very basic question, but very important, especially at the what side? Ultrasound guided. Anybody who would still prefer?
See, it is nowadays you go by ultrasound. This is a way of practice.
Right.
But that was not previously. We used to locate the maximum done whether it is suprapubic or on the flank.
Okay.
And particularly the frequent point with the right iliac neck bandage point, or the distance between the umbilicus and pubis midway.
Okay.
Ask patient to empty the bladder and then just put in it. If patient is obese, give then with the long needle, if the patient is thin, with the 1.5 inch. That was, but nowadays the way of practice is to locate the fluid by ultrasonography and ultrasonography guided. But if you ask me, I have never done ultrasonography guided by ascitic therapy.
Yes.
And I am 100% successful.
Right. So
Yeah, practically, I would like to say, practically we do without sonography. If it is a frank use ascites.
Right.
Another problem is that the patient is admitted in my clinic. It's a single specialty clinic. We don't have USG machine. And if we want to do tapping, we have to do without USG guided. Otherwise, we have to take the patient where USG facilities are available.
So this is
So
also-
usually we do without USG guidance.
Yes, absolutely. So sonography guided is a safer technique these days.
Yeah, it's
considered
definitely safer and CTA point of view preferred.
Is what sir has mentioned.
Yeah.
We do it clinically bedside even these days.
See,
Not
legally it has to be
everybody
done.
can afford the sonography guided tap, which can be done without any charges bedside at our clinic or hospital.
Era has changed.
Era has changed. Yes.
Now the insurance company comes in the picture.
Right. Yeah.
Right? The practice of medicine has changed so drastically. If you create some problem in a one patient only, you are liable for punishment.
Absolutely.
In 99%, you did it fine, nobody recognizes it. So go according to what the guideline says.
Alright. Again, second most important thing, since we know that the platelets are 40, INR is 2.6, would you want to give some products or platelets, FFP, anything?
See, these cirrhotic patient most of the time having, even though there is no hypersplenism much, the WBC count is normal. But still, even with the presence of hypersplenism, if the bone marrow, if you think that bone marrow is producing good number of platelets, there is no reason to give any product.
Right. Anything for the INR? Anybody has got any insight or inputs on correcting the INR? Because if you are planning a diagnostic or let's say a therapeutic tap, would you routinely advise for any correction?
This is a very minor procedure. I don't think that correction is required.
Yes. So moving ahead, as we discussed, the preferred site of tapping, midline above pubis, like you mentioned, sir, was the preferred one. But then many times the bladder and the collaterals can come in the way. So we prefer left lower quadrant or the right lower quadrant. But then we have to ensure that many times patients who are on Duflac, patient have got a dilated cecum, then the cecum is at times distended because of Duflac. There are chances that the patient can have some perforation using a long needle. So we have to ensure that the preferably patient should empty the bladder and the bowel and then take him out. That should be the ideal setting. Similarly, when you have left lower quadrant, again patients who are severely constipated, we should ensure that they are given good laxatives, preferably not osmotic laxatives, so that they don't have a distended sigmoid colon, which can be at risk when you are puncturing. Okay, so these were just a few recommendations as we discussed. Use of ultrasound guided is nowadays the preferred technique, of course, and it also helps many times if there are multiple pockets, then the pocket having maximum fluid needs to be removed. So sonography guided is the preferred technique and the safer technique these days. And rest all are what we all know of, where to use the needle, how to put the position and all. So we can skip this part. Again, institutional experiences, we do not recommend correcting INR and giving platelets or giving any products, considering the risk because of it. For diagnostic tap, usually there is no need of correction. Yes, for therapeutic tap, there are few certain conditions. Let's say the patient is severely in sepsis, there is DIC, there is low fibrinogen levels, then we may consider giving some correction. Otherwise, still, it is not indicated. So it's a case-based discussion and an individual judgment whether to give a correction when you have a very high deranged INR and when you have severely low platelet counts with patient in sepsis, shock, ILS, all those complications. Then probably we can think about giving a tech-based correction if we have the tech facility available. Okay, so you do the ascitic tap and then how would you want to collect the sample or collect the liquid, and how would you want to run the labs? I mean, on the ascitic fluid?
One small question before that. If you are clinically confident enough that there is no infection, there is no SBP or there is no other secondary infection, will you still go for ascites tapping? Is it mandatory?
Yes, yes.
At least for the first time.
Every new onset ascites needs to be done. 30% of the cases of SBP are asymptomatic. You cannot have any pain, you will not have any fever or any toxic symptoms, but still there would be a rise in the WBC counts. So a new onset ascites in any patient warrants a diagnostic tap to understand what is inside. So we'll discuss on that. So coming back to this question, how would you want to collect the
Why
sample?
do you restrict to liver only?
So that's my specialty.
Right? Because we do not know the reason of ascites.
No, so we are discussing, we can always have the various discussions. Let's say this is a liver patient, but he can have a different manifestation. Patient can have tubercular ascites. So we'll come to that. Patient can have underlying cardiac involvement also. That can change the values. So we'll come to that. But for this, these are some basic instructions that I think we should always advise, during our residency and all, while we are collecting the ascitic fluid. We should always send the fluid in plain and EDTA. Important is the culture. So the culture needs to be sent in a blood culture bottle and not in a plain bottle, which I think, I don't know what is the practice here. I mean, you would want, you can always say, do you send it in a blood culture bottle? Okay, great. 15 to 20 ml of fluid needs to be sent in a blood culture bottle at the bedside.
If you suspect SBP and if you send that ascitic fluid in that blood culture bottle, what are the chances of it being positive?
60%.
60.
If you are suspecting, yes, send it.
60.
Yes.
With 20 ml of ascitic fluid, you can get 60% positive.
Yes. So basic lab that we run, it's a routine cell count. We need to send for the differential, protein and albumin. Case-based scenario, we can ask to send for LDH, sugars, ADA, cytology, amylase, triglycerides. So this is on the basis of, let's say, symptoms, not in this case, but in general. If we are suspecting, let's say, a perforation or a secondary bacterial peritonitis or a surgical abdomen, then probably this sugars, amylase, triglycerides can help. Let's say we tapped a chylous ascites or a white ascites. We suspect probably the triglycerides levels can be more than 200. We are having a lot of abdominal pain. We suspect probably there is underlying pancreatitis. We can have pancreatic ascites. The amylase levels would be more than 1000. So now this we have the ascitic fluid report. So the fluid was straw colored. There was no coagulum. So gram stain and AFB stain usually is done routinely, but it has got 0.8 because you need at least 10,000 organs for the stains to run positive. And many times the ascitic fluid may have just 1 or 2 organisms. So the stains may not always come positive. So the sensitivity and specificity for gram stain is very low, but it is done routinely. Total RBC was 500, WBC count was 800. It was a neutrophil predominant one with a protein of 1.5 and albumin of 0.95. Okay. So now we have the preliminary report. Now since it's a liver case, this patient has got basically a high SAT, low protein ascites with SBP. Okay. We have the diagnosis. How would you want to manage this patient?
How frequently you get this minded RBC? Here the only abnormal cat is minded RBC. Will you consider with a traumatic test?
No. So now it depends on that side. When you are doing a tap, let's say if it is a hemorrhagic ascites or a traumatic. So usually hemorrhagic ascites, the blood will not clot. For a traumatic one, it will clot. Second, when you have counts more than 10,000 RBCs, it is then you need to give a correction to the WBC count. So every, let's say 750 RBCs, you need to reduce the WBC count by 1. So that gives you the correction. 500 is still okay. If you have more inputs, I would want to understand that, but that's how we deal with it. So RBCs, it's okay, but the fluid was straw colored. So some amount of RBCs are expected. It is only when you have 10,000 RBCs or a straw, or rather than a straw colored fluid, you have hemorrhagic tag or it's a completely red tag. It is then you can have some fallacies in the WBC count correction or calculation.
What is the ratio?
So,
Set.
so that we need to calculate.
We have to calculate.
Yes, yes. So if it is given in the lab, fair enough. Otherwise, on the same day when you know his albumin is 2.4, serum albumin, and here we see that ascitic fluid albumin is 0.95. So this is definitely a high side ascites.
So you have to calculate those things.
So I have given you the diagnosis. It's a decom CLD with ascites, high side low protein ascites. There is SBP and hyponatremia. So how would you want to manage the case? What would you start off with? Sir, maybe
Wait for the culture report.
wait for the culture. Would you not want to give empiric antibiotics? Cultures may take around 2-3 years.
So for example,
Okay.
And second, they usually we get.
This is mostly a transfer migration of organism.
Yes.
Right? And hence you select the antibiotic after taking the culture,
Yes.
so that you will be wiser later on, sir.
Agreed.
Because the decompensation took place because of SBP.
Yes. So the guideline says start off with third generation cephalosporins, preferably when it is a new onset ascites, community acquired, patient is not previously hospitalized, not had previous recurrent SVP attacks and all. Now, if you have, let's say, ESBL producing organisms, or let's say patient has had a hospital setting and an ascites, then probably carbapenems can be started. Levoflox is not used commonly. Norflox, Ciplox can be used, but then that is mainly used for, let's say, if you after sensitivity report you have quinolone or as an SBP prophylaxis. So third generation cephalosporins, ceftriaxone preferred one, or peptides commonly used these days.
Hardik, in that case, I have one comment. If you are expecting spontaneous bacterial peritonitis and you are also suspecting previous exposure to hospital, will your patient be this stable? Or it is a secondary bacterial peritonitis you are describing?
So second, no. We are discussing spontaneous bacterial because as we run through the case history again, this was a new onset ascites. Patient did not have any previous admission in the past. Or let's say,
here will you consider third generation cephalosporin or carbapenems at all?
yes, yes.
Carbapenems
Ceftriaxone.
here also?
No, not here, not here.
Okay.
That's
So
what I was
describing
discussing.
was probably secondary bacterial rather than spontaneous. In spontaneous,
So
you
if
will
the
never
patient,
consider
let's say, is
carbapenem.
very toxic, we always start off. Guideline says we always start off with third generation cephalosporin.
Okay,
That
fine.
is the
or
preferred one.
Oflox or Norflox, right?
No. Third generation cephalosporin is the preferred one.
Okay.
Or at the max you can start off with, let's say, piperacillin tazobactam. That's about it.
Okay.
The case scenario which I was discussing was that if the patient has had recurrent SBPs, has had recurrent hospitalizations, comes to you with lot of, let's say, you suspect complicated ascites, or let's say there is recurrent ascites, recurrent SBPs, there is AKIs, then probably carbapenems can be your first choice.
So is it a diagnosis SBP?
Sorry?
That diagnosis is SBP or not?
Yes. Always suspect SBP in a patient of chronic liver disease when you have ascites and patient has got any decompensation, let's say GI bleed, or patient has got EKI, or patient has presented with abdominal pain and you've ruled out surgical abdomen.
So I may be wrong, liver body and over so but this is probably a secondary bacterial peritonitis rather than spontaneous. Spontaneous, that is translocation that sir was saying, will not cause this type of clinical picture that you are discussing. That is what I was
So that's what I gave you two clinical pictures. Considering this case, this is spontaneous bacterial peritonitis. This is usually a single organism. When you have secondary bacterial peritonitis, it is usually a case of a surgical abdomen.
Exactly.
So that you have to rule out on the basis of history. You have to do CT scans and rule out, let's say, if there is perforation or any other intestinal pathology that may have led on to a
So
perforation.
let
or
me
a
ask you
surgery.
directly. Have you come across any of the scenario where it is pure SBP, but the organism is resistant and you need to give carbohydrate?
No.
Okay, that was the question.
So that's what I gave you two clinical settings. Depending on that, you have to decide the choice of antibiotics. This patient is pretty much stable. Probably on a PD basis, you can still wait, like sir mentioned, you can do a culture. You would not want to start. Wait and watch policy can be applicable, but clinically, SBP, if it is left untreated, can lead on to further worsening. So it is advisable that always start off with, let's say, a daycare policy of giving antibiotics initially till we understand how the culture report is and how things are trending.
That's fine.
Okay.
So
So,
next, hyponatremia is still.
yeah, hyponatremia. Yes, sir.
Do you consider methanol as a
No. You can consider because of the anaerobic coverage, but many times the organism that we commonly encounter, and
demography is changing?
but metronidazole, sir, as per the guidelines and as per what experiences are.
Guideline is given by the few people only. It's not an experience base. Right? It is for insurance company. Should we believe the insurance company only?
No, I think we should believe what the expert guidelines says and what our clinical experience also says. So you can give, there is no harm in giving an anaerobes, because many a times blood cultures and ascitic fluid cultures do not give a growth of anaerobes. So that coverage can be added, but preferably cephalosporin third generation gives a broad coverage, is sufficient in an uncomplicated ascites. Let's say it is SBP new onset first episode. Cephalosporins for 5 to 7 days is the ideal thing.
So what is the most common organism isolated as an
E. coli.
E. coli.
So now next, I think we were discussing how would we manage the case. So now patient did receive 3 days of IV antibiotics.
Hyponatremia portion.
Yes, this hyponatremia you want to manage, sir? How would you want to manage?
You not. Why not hyponatremia?
No, I think I need your inputs
Fluid
on
restriction.
hyponatremia.
Here is about the fluid overload.
So sodium was 126. Would you want to restrict fluid? Or would you want to correct
Here the
hyponatremia?
hyponatremia most of the time due to fluid overload.
Yes.
So either you correct fluid or restrict the fluid.
Right. So this is mainly a dilutional hyponatremia, which is 126. Patient is not symptomatic, so we need not aggressively correct the hyponatremia by giving 3% NS or anything. Fluid restriction can be managed in this case, setting up around 1.5 liters and all. Okay, that should suffice. I think. Yeah. So patient did receive 3 days of IV antibiotics, IV albumin, and now patient is requesting for discharge, does not have insurance. So he is paying by finances cash. So now he is insisting kindly discharge.
So
So
lawyer can still come.
sorry.
Meanwhile, you have received that culture report or not?
So that's what we
Insurance
discussed.
company will not pay, but lawyer will still come.
Yeah. So now you are planning a discharge. You want to ensure that patient ने घरे मोकलावा છે સારી રીતે મોકલાવા છે. Do you repeat an ascitic fluid analysis to confirm whether the counts are going down and treatment is being successful, or no? Like, what would be your approach in this case?
Before that, whatever we have sent, we have received or not, that we would not confirm.
So let's say
Culture report
culture.
has already come.
So I'll give you two settings. Cultures is negative. Okay. But you had a count which were high and there was SBP on your first. What would be your take on this? Culture is negative. Let's say the organism was not picked up on the culture.
Then empirically, whatever we have started, we continue.
Yes. And let's say the culture is positive. It says E. coli, which is pan sensitive.
Then also same to be continued.
So you have it.
IV antibiotics for how many days? Empirically.
So ideally, IV antibiotics is to be given for 5 to 7 days. Ceftriaxone 1 gram, OD is the recommendation. We always give in our setting 1 gram BD. Okay. But let's say patient is insisting for a discharge. We have a culture negative, and patient is not showing any signs of toxicity. Let's say patient is improving and responding. So probably after 3-4 days, we can switch on to oral antibiotic of the same class, let's say a third generation
The
cephalosporin.
patient was absolutely asymptomatic. So in which regard he is improving?
That's what. So if patient is not worsening further, that means it is improving. And my question to you was, how would you want to confirm? So you can give me the answer. How would you want to confirm before sending the patient discharge?
It won't be, we will not be retained. That is one thing.
Subjective
So
is
clinical
objective.
decision.
Subjective you say the patient is not worsening further.
Yes.
Objective you have to do.
Would you expect any reduction in the ascites level as well by giving antibiotic?
So
We are not giving diuretics, right?
diuretics we've not started.
Okay,
But
so-
albumin can partly help in having some diuresis.
So even the patient is feeling good, giving antibiotic and albumin.
So an ideal setting would be tell him on an OPD basis take 5 days of IV antibiotic. That is number one. Second, if patient is not worsening, you can switch over to oral antibiotics or let's say cefixime because we've given a third generation cephalosporin. Third, in this setting, I would not do a repeat tap because I know patient has not worsened. But given the change in the scenario, let's say patient is not showing signs of improvement, ascites is worsening, now patient starts throwing up fever, patient has started, you do a creatinine and patient starts showing that creat has worsened. That means that patient is probably, or let's say you do CRP or counts have started rising. So patient is not improving. In that clinical setting, probably you would want to repeat an ascitic tap to understand whether your choice of antibiotic has really helped or the organism inside is probably growing resistant and not responding. So in that clinical setting when patient is not improving, you have worsening creatinine, you have fever, you have rise in the CRP markers, probably patient can land up into ILS or not. You have to repeat a tap after ideally 48 hours to document whether there has been more than 25% reduction in the white cell count. If that is there, that means your antibiotics are working well and then probably you can continue. If not, and given the worsening situation of the scenario, you will have to change to or escalate the antibiotics. So pertaining to this case, probably in this case, I agree I would not want to repeat an ascitic tap. Probably I would convince the patient to take 5 days of IV antibiotics or change over to oral.
Diuretics should be given or not?
Sorry?
Diuretics.
We'll come to that. Yes, we'll come to that. Of course. Patient is going to ask you, give me a final treatment on discharge.
Yeah, he has
So
dilution
I'll come to that.
hyponatremia also.
Yeah. So if we focus on the third, an inability to achieve a decrease of at least 25% or more of in the PMN counts after 48 hours of treatment should be considered as a therapeutic failure and warrants change of antibiotic. And when you do not have an adequate resolution of the infection, this possibly raises the suspicion of secondary peritonitis. So that should be ruled out. So again, now you've treated the patient, let's say you've given 5 days of antibiotics and patient has not worsened further. Patient has had SBP. Would you want to give a secondary prophylaxis in this setting? What would be your choice of antibiotics?
Norflox.
Norflox. Let's say now I've always raised up this query with my bosses. Norflox patient को quinolone allergy है, नहीं दे सकते. What next? What would you want to give?
Potramixol.
Okay. Single strength, double strength.
Double strength.
Double strength. So it is single strength. Let's say sulfa allergy है, quinolone की भी allergy है.
Septic.
So yes, some antibiotic needs to be given. So preferably it is Norflox 400 OD. If patient is unable to tolerate, let's say it's very rare, but if you have a quinolone allergy, then probably you can choose among cefixime or tremoxazole OD doses. Okay.
Yeah.
So it is to be given till your ascites resolves, till the time you have fluid in your tummy. Antibiotic after a setting of SBP needs to be given indefinitely till ascites is gone, it is dried up.
Was there any criteria of serum albumin level less than 2.5, more than 2.5 to give prophylaxis? Was it something like that?
We'll come to that. So now, this next question is for you because you put up that question. do you routinely prescribe prophylactic antibiotics with ascites without any prior episode of SBP? So the question you were addressing was a primary prophylaxis. So in these settings, you can give a primary prophylaxis. So let's say patient does not have any SBP in the past, but patient has had a high med score or an AKI, there is hyponatremia, CTP is more than 9, and your albumin levels are less than 1 or a total protein level less than 1.5. In that setting, yes, patient does require a primary prophylaxis, an antibiotic that needs to be given, even if there has not been any past history of SBP.
Here any role of gut sterilization rifaximin?
So there is no role of rifaximin in a setting of SBP. Rifaximin is ideal in a setting when a patient has had an episode of NCAF. There is no primary prophylaxis of rifaximin in SBP, not in setting where patient has not had hepatic NCAF. So Dufelac or osmotic laxative loose syrup is the ideal treatment for hepatic NCAF to avoid one. Once you have it, you can add in rifaximin. So now patient is planned for discharge. Patient's BP is fine, creatinine is 0.8, sodium has improved. Patient is asking, पेट का पानी कैसे निकालेंगे? What diuretics you would want to give? Andecton. What dose?
Minimum 100.
Minimum 100. Anything else?
Start with the low dose and then
Loop diuretic.
low dose and then
Low dose. No, but then
Andecton low dose.
if you want to give both together or one at a time. Let's say you want to give loop diuretics and Andecton in combination. Andecton or okay.
You have to
And
take
you want to give 100 milligrams sir, or Andecton and see whether patient is improving.
Patient has only moderate SIT. You don't want to become asymptomatic patient to become symptomatic. So much of electrolyte in there is by giving patient has moderate SIT in this case. So Andecton will suffice. You don't want to make asymptomatic patient symptomatic.
also take care of sodium and potassium. When you are giving either low diuretics or spironolactone, take care of sodium and potassium. You have to see frequently.
Anything from here? I mean, I would want you all also to add in any inputs.
They are pure cardiologists, so we don't have.
But the cardiologists do
These
use
two members are
diuretics.
listening frequently, so they can have insight.
Cardiologists do use diuretics. So in this setting, let's say you have a walk-in patient, you diagnose, you
But
ruled out cardiac causes before referring it to anybody else.
They will not go beyond 50 milligram of Hardik. Their our story start beyond that, so it's fine.
So what has been your maximum dose of diuretics if you given?
If you are giving
Given after 200 patient has started.
Along with fusilade. That will
if the cost is not very high, in a liver disease, and if you often happen,
Immediately first eplerenone without Andecton. Why sir?
gynecologist.
But let's say patient does not have gynecomastia.
He will never ask.
but that
Please
is
call
But
it.
not every patient
As
has
I told you,
gynecomastia.
if the patient is affording,
Ah.
you see, an affluent person, why he should have a gynecologist?
But not every patient on Andecton has gynecomastia.
Many patients.
secondly,
In a chronic
it occurs because of cirrhosis also, not just
Right.
if it has to
So
occur.
sir has raised up a very valid point that yes, if you anticipate that Andecton is causing, let's say gynecomastia in a couple of months and all, not tolerant, then you can switch over to eplerenone or ameliorate.
You're right, you can give an option to patients. See, now it is a free market. They can't develop, then you have not told me. It's American approach.
Okay, so we'll discuss about the dose of diuretics later, how much to give and what all precautions. Patient does ask, every patient asks, diet में क्या लूँ sir? Very important. If you don't give diet, you are not a good doctor. So diet is something that should come first along with your medications. So what would you want to advise to your patient on the basis of diet and some precautions?
What restriction is.
How much salt restriction?
That
कितना
is
allowed?
2 gram per day.
2.5 gram.
2.5 gram also.
2.5. Anything else besides that? 2.5. Water restriction, would you want to still continue? Sodium आ गया अभी 132 आ भी क्यों है sodium?
Then most of the time I ask my patient, there is a weighing scale.
Okay.
If he puts on weight in spite of doing salt restriction, so obviously the fluid restriction is required along with diabetes.
Anything sir you would want to add in? Only salt restriction, any other diet advice? High protein diet?
I'm asking you now, will you give Vaptan? Why?
We'll discuss. Vaptans is there waiting, that slide is waiting for you, we'll discuss. Vaptans as of now is not needed. I
Not
said
needed.
132 sodium has come up. You don't need Vaptan.
And a liver disease. You avoid it.
Patient is asking for diet right now. He does not understand Vaptan. He says, sir, Vaptan छोड़ो, अब मुझे diet बताओ. घर पे मैं क्या precaution लूँ? What will be your best advice?
Not
Yes.
a Vaptan or diet.
So yes, salt restricted diet is something that everybody should aim for.
So
So
first class protein.
yes, high protein.
High protein, that is first class.
Yes, but
High
salt
biological
salt
value.
restriction के साथ important water restriction. Would you want to give a water restriction or not? How much?
That depends on the season. When it comes to Baroda, where humidity and high temperature prevails, in summer the water restriction is different, and in winter the water restriction is different. In winter you allow 1 to 1.5 liter, and in summer 1.5 to 2 liters.
So important is yes, salt restriction very important. 2 gram is something that is ideal, but many times 2 gram leads on to aversion of food. Patient does not eat. That worsens the sarcopenia in a cirrhotic setting. So that itself can lead on to other complications. So you can be a bit more liberal. You can allow around 3 to 4 grams or 5 grams. Our average Indian diet is around, let's say, 12 grams of salt we take usually. So we can still allow 4 grams, 5 grams. There are other guidelines. Some say you restrict to 2 grams. Some says you can give a liberal salt restriction by giving around 4 to 6 grams. So important here is that explaining to the patient how to measure the salt. So the best way and the simplest way is carrying a salt sachet and explaining to them that 1 gram salt sachet दिन में 3 बार या 4 बार आप लो. That is enough. खाने में आप कोई भी नमक मत डालो, कोई भी मसाले मत डालो. There are causes of surreptitious salt intake which we will discuss. We should not be allowing them papad, bakery products, processed food. Okay? Yes.
Achar.
All those stuff. Achar. All those stuff is not to be allowed. Fluid restriction in a setting of hyponatremia, yes. If till the sodium does not come up to let's say above 130 and all, we can continue following fluid restriction of 1.5 liters. Otherwise, what the institutional experiences and the studies says and what the guidelines also impart that fluid restriction is not a mandate in a setting of liver cirrhosis unless there is hyponatremia less than 125. So once the sodium improves, we can allow them liberal fluid is what needs to be understood here. So we were talking about surreptitious salt intake. Achar nahi, no other salts. कुछ कहते हैं कि ब्लैक सॉल्ट ले सकते हैं, रॉक सॉल्ट ले सकते हैं, नहीं ले सकते. पापड़ कंप्लीट नो. सी फूड, पैकेज फूड, बेकरी प्रोडक्ट्स, ड्राई फ्रूट्स which are usually salted not to be allowed. Various sauces outside not to be allowed because all these have got salt. We need to mainly restrict the salt and allow only 3 to 4 grams or 5 grams per day provided there is no additional salt intake. Because all this would be giving a surreptitious additional salt intake. So this is very important to impart to the patient. So this is what we were just discussing. Now let's say again the continuation of the case. Patient did not follow up as early as you had instructed. You had mentioned you start diuretics and you want to follow up with the patient with creatinine electrolytes, but patient did not follow, and later on patient presented with the abdominal distension, there were cramps, and BP was 90/60, creatinine which had come down to 0.8 again has come up to 1.1. Sodium has come down to 120 now. Potassium is 3.5. What do you think may have happened? So patient has had a diuretic overdose. Probably he did not monitor and there have been side effects. So he is completely dry from the periphery. Abdominal distension may have not responded. BP is on the lower side. So it's like a mixed
intravascular fluid is low.
Yes, you are saying it is persistent abdominal distension.
Yes. So patient has died from the periphery, but his abdominal fluid or ascites may have not mobilized. So there is a mixed picture. He is dehydrated, diuretics have overworked causing him side effects, but they have not worked for his ascites. So there are chances that he might be going into a refractory ascites. So what should be done next? Of course we stop diuretics. Should we give IV albumin or crystalloid or tolvaptan, sir, in this setting?
He is going for a hepatorenal syndrome. Now you have to define what kind of hepatorenal syndrome is you are facing, and your strategy will depend on this.
Okay. So in this setting, yes, we stop diuretics by all means. We know that patient is having cramps, patient is dehydrated, there is AKI, there is hyponatremia. So diuretics has been probably the double-edged sword for him, not work for him or partly work for him. So we stop diuretics and we start off with IV albumin. Okay. So basically, this case was just to sensitize as to how we need to approach a case. If there is SBP, no SBP, diuretics, antibiotics, SBP prophylaxis, the diet follow-up and the routine follow-up with the labs. Because when you start off with diuretics, it is very important to monitor the creatinine electrolytes after 3 to 4 days routinely, at least for a week or 2 weeks, till we understand that patient has responded well and there are no side effects setting in. And then we optimize the dose of diuretics.
This case is a mixed one.
Which-
Nash and cash.
Yes,
You have not finished the diuretic business.
I come to that. It's still there. Okay, so diuretics, since we were discussing, we start off with aldactone like you said. Ideally we start off with 50, 100 is acceptable depending upon how the patient tolerates. Now, when a patient has got new onset, let's say in this case, spironolactone is the ideal one because it is an aldosterone antagonist. And in the pathophysiology of ascites, there is renin-angiotensin aldosterone axis which has been activated. So aldosterone antagonist is the prime player. Okay. Now many a times it has been found in the experiences that spironolactone may not or sufficiently or effectively act for the diuresis. Patient says jaldi पेट का पानी खत्म करना है, and probably aldactone may not be or would be slow to act. So the trend or the practice is to add loop diuretics. So that
what
there is-
happened when then lectrin circles.
So the dose optimization is important and monitoring, sir. So ideally what sir mentioned here is 100 is to 40. For an aldactone of 100, furosemide 40 is to be added. There cannot be a mismatch in this ratio, otherwise the side effects of one will complicate and reduce the efficacy of the other. Because what has been found is, if aldactone is causing some side effect, furosemide tries to overcome that, especially in the dyselectrolemia, potassium. So 100 is to 40 should be the ratio, aldactone and furosemide. And then depending upon the response, like sir mentioned, daily weight chart आप करो, ताकि आप देखो कि how effectively there has been a weight loss. Let's say patient has only ascites, no pedal edema. Then the target weight loss per day should be at least of half kg. That should be your ideal one. And let's say patient has got pedal edema with ascites, then your target weight loss per day should be of near 1 kg. Alongside, when you start off diuretics, every third day in the initial first week to 2 weeks, you should do creatinine electrolytes. Because we need to understand if the patient is responsive or there is a setting of acute kidney injury or dyselectrolemia that per se does not allow us to optimize the diuretics, or probably later on patient can land up into diuretic intolerant ascites, which can probably lead on to a setting of refractory ascites. So 100:40 should be the ideal dose. We can go up till 200 to 80, but beyond this, Indian scenario, Indian setting, patients do not tolerate. So many times we do not see the setting of diuretic resistant, where they say that you can give up till, let's say, 160 of furosemide and 400 of aldactone. वो उतने सीलिंग डोज तक कभी हम जा ही नहीं पाते. तो usually what we commonly see in our setting is we always see a diuretic intolerant or an intractable ascites because of acute kidney injury, dyselectrolemia, patient landing up into hepatic NCAP due to diuretics. So that's basically the.
Can we use torsemide
Yes.
instead of furosemide?
Yes. Again, sir had mentioned that for 5 milligram for 20, 10 milligram for 40.
Torsemide plus aldactone has more chances of hyperkalemia.
Hyperkalemia, yes.
So-
Furosemide plus.
So head-to-head trials between furosemide and torsemide efficacy is the same. There has not been any one drug superior. Just that torsemide is a long acting and furosemide is a short acting glutide.
6 hours.
Yeah,
That's 6.
that's it.
6 further from that.
Last question.
Effects last for 6.
So should we discuss the second case or we'll go up with the guidelines quickly?
Please go to the guideline.
Guidelines. Okay. So these are like 3 practice guidelines, one from the American Society, one from the European, one from the UK. Why we are discussing ascites is what commonly cirrhotic patients presents with, not much into the pathophysiology, just understanding why ascites is important because it adds into the poor prognosis. Ascites with poor prognosis predictors, again, if there is alongside hyponatremia, low blood pressure, AKI, low urinary sodium, then it means that your ascites is going to be a troublemaking situation for physicians to manage. So again, ascites definition and severity, we see that mild, moderate, severe is your severity defining criteria. Mild is something that ultrasound picks up, it can pick up around 100 ml of fluid. Moderate is something that we pick up, there is shifting dullness, horseshoe dullness, and severe dense ascites is something that we know it's completely like having a fluid clinically. Again, uncomplicated and complicated ascites. Uncomplicated ascites is something that you have just a new onset ascites without any SBP or an AKI, and complicated ones are usually the ones with SBP or an AKI. So here they have mentioned about the treatment protocol. So when you have mild ascites, we usually allow for a salt restriction. It has found only 10 to 15% patient response to salt restriction because they don't, are very effectively managed on salt restriction. So a low dose diuretics in a setting of mild ascites can be started. So what the practice mentions is, when you diagnose an ascites on clinical examination, always investigate. Salt restriction is something you should start off with. Low dose diuretics with careful monitoring needs to be understood every 3rd day. Creatinine electrolytes needs to be done initially to understand whether the patient is having any diuretic related side effects.
In patients with ascites and cirrhosis, how much rise in creatinine would you consider significant?
So depends upon if you have a baseline creatinine. If you have a baseline creatinine of let's say 0.8, the patient know 0.8 hai, and the patient comes with 1.1. So more than 0.3 milligram rise in the creatinine from the baseline is an indicative of acute kidney injury.
Once again, creatinine is a very poor marker. Right? Very little range. Right for criteria. Clinically, you go for it as such and wait whether the hepatologist syndrome is taking place or not.
So muscles are less.
Yes.
Creatinine is-
So there is sarcopenia. So let's say in a setting where you have a creat of 0.4 and the next day suddenly that cirrhotic patient comes up with a creat of 0.7, 0.8. So we would say अरे creatinine 1 के नीचे है, normal है, कुछ नहीं हुआ. No. In a setting of cirrhosis with sarcopenia, this rise of 0.3 from the baseline, if we know of, is still significant.
Creatinine is a very poor marker.
Any role of GFR?
So again, GFR is based on creatinine. So we calculate the creatinine values, but urine output and creatinine increase from the baseline is something very important. Okay, about diagnostic tab we discussed. All guidelines mention that every patient with a new onset ascites must undergo a diagnostic tab. Serum ascites albumin gradient, again, it's very important to calculate if your lab is not giving to understand whether we are in the high SAT range or the low SAT. So high SAT is something that determines portal hypertension in 97% of the cases. So it's very important to understand here whether we have a high SAT high protein, high SAT low protein, low SAT low protein, high SAT low protein. So important here is, because we are discussing liver, usually the typical scenario is it's a high SAT that defines portal hypertension. Now when you have high SAT with low protein, it is usually liver cirrhosis. But if you have high SAT high protein, that means that probably liver protein production is optimum, then probably we have to rule out other causes. So what causes can lead on to, let's say, high SAT and high protein? Yeah, so usually the cardiac causes is something we need to rule out. Now when you have a low SAT is usually a non-portal hypertensive. It is usually the exudative one. So when you have a low SAT and a low protein, which means that there is a protein loss from the body. It's mainly or most commonly a nephrotic range proteinuria or a nephrotic syndrome. But when you have low SAT and high protein, which means that there are a lot of proteins in your abdominal fluid as a reaction to probably, let's say, tuberculosis or tubercular antigen or malignancy. So very limited differentials to give you the clue towards what etiology we can make out from the SAT and the total protein count in the ascitic fluid. Again, the same that we discussed. Okay, ascites management, we were discussing. All guidelines do mention about moderate, except for the American, which mentions that 2 gram is something that you need to restrict. But otherwise, Indian setting or sarcopenic patients, they have aversion to food, so we can be a bit more liberal, and we can allow around 4 to 5 grams, depending upon how the patient is following your other salt restricted or additional salt intake. Okay, so diuretics, again we were discussing. Start off with spironolactone 100 milligram. You can so EASL guidelines said increase every 7 days, but now the new guidelines mention that you can increase after every 72 hours based on the monitor to get that optimum efficacy. Adding furosemide adds in to the rapid mobilization of the ascites. So dual diuretic therapy is something that can be practiced. How do you assess the response to diuretics? Again, we discussed, we do a daily weight charting. We see that there is a weight loss of 0.5 to 1 kg per day. If the patient is diuretic quite more, let's say beyond 1 to 2 kgs, you need to be watchful, because that means that probably you are giving a higher dose of diuretic, or probably patient can lead on to an AKI or a dyselectrolemia subsequently. Urinary sodium and urinary electrolytes we don't routinely do in our practice, but to understand the efficacy that probably diuretics are working, then urinary sodium can be done. So ideally when the urinary sodium or a diuretic is more than 30, which means that diuretics are working. And urinary sodium to potassium ratio of 1 and above, that means that diuretics are working.
How much is left of?
Just couple of slides. Muscle cramps, very common side effect of diuretics. Ideally treat with IV albumin or baclofen in this setting. Hold diuretics for a while till the symptoms resolve. I think we'll skip this part because this itself is a elaborative topic. Role of IV albumin. Yes, so patient usually who are refractory ascites, we need to give IV albumin, and important here is about doing a large volume parasynthesis. So basically IV albumin, 20% human albumin that we commonly practice, needs to be given when you are doing a therapeutic tap. Especially what guidelines says you give it beyond 5 liters, but because we want to avoid entity called post-parasynthesis circulatory dysfunction. So even if we are tapping around 3 to 4 liters, we can give IV albumin. Otherwise the guideline says beyond 5 liters, every 1 liter of tap requires an 8 gram replenishment of the IV albumin. And LVP should not go beyond 6 to 8 liters. Otherwise patient can have an AKI or an hypotension on that very day subsequently. And post-parasynthesis circulatory dysfunction usually manifests on the 3rd, 4th day when you have an acute kidney injury or an hypotension.
See, is there any guideline if you are doing 5 liters of fluid? How much duration it should be tapped?
So,
Within 1 hour, 2 hours, 3 hours, 4 hours? Is
So-
there any flow
In a day.
so you can't control the flow, sir. In a day,
And nowadays, you know, that bar is always there.
so if the fluid is coming out rapidly, I think 1.5 hours is maximum that the fluid can be removed. It cannot go beyond this. In a day, in one setting, if you are doing an
At
LVP,
least wait, if we are running 5 liters of fluid, is there any guideline to be removed over a period of 2 hours, 3 hours, 4
no,
hours?
no.
You know, this is like a acute diarrhea vomiting. Even though there is no diarrhea vomiting, but you are removing 5 liters of extra cellular fluid, that may cause hypotension.
But that is why you are giving IV albumin. The albumin is to be given because you are removing fluid and you want to avoid hypotension and acute kidney injury in this setting. So there is no time duration by which you want to remove over 1 to 2 liters, 3 liters. IV albumin is something that you need to focus on when you are doing an LVP.
What is LVP?
Large volume parasynthesis, that is a therapeutic tap.
Okay.
Again, about hyponatremia, guidelines give a difference of opinion. Diuretics can be held off or given cautiously in a setting of less than 130. Stop it when you have less than 125.
Rather than finishing it rapidly, can we discuss it in next hour?
Sure, it's a
It happens, everybody agrees.
Sure.
But everybody is rushing for that.
I can see that. Then that's okay.
Okay. Very nice.
Sure.
Huh?
Yes.
Good.